Hi students, hope you're all doing good. In this video, we are going to discuss about liver disorders in pregnancy. Okay, we'll discuss about the various causes of jaundice in pregnancy, followed by hepatitis and followed by the specific disorders in pregnancy. Okay, so liver disorders in pregnancy. Now, we'll first see the causes of jaundice in pregnancy. Okay, so jaundice in pregnancy can occur due to obstetrical causes first. Okay, we'll see some obstetrical causes. These include number 1, obstetric cholestasis. Number 2, acute fatty liver in pregnancy. Number 3, it can also arise due to severe preeclampsia or eclampsia. Number 4, it can also arise in HELLP syndrome. Then can also be seen in cases of severe hyperemesis, that is hyperemesis gravitarum. And sometimes it can also occur if there is a DIC or endotoxic shock. Clear? Okay. And among these causes, if you see, mostly obstetric cholestasis is seen during 2nd or 3rd trimester, and acute fatty liver of pregnancy and severe preeclampsia and eclampsia usually they will present during 3rd trimester, and HELLP syndrome can present anytime in the 2nd half of the pregnancy, and severe hyperemesis can present in the 1st trimester even. Clear? So, we'll see some other causes in jaundice. So, other causes of jaundice in pregnancy include number 1, viral hepatitis A to E, then chronic hepatitis, then cirrhosis, then hemolytic causes, even due to gallstones, or sometimes it can also arise due to drugs also. Okay, clear? Right. Now we'll start discussion on intrahepatic cholestasis in pregnancy. So, intrahepatic cholestasis in pregnancy. See, this is one of the most common liver disease that is unique to pregnancy. Okay, so it is unique to pregnancy and it is the most common liver disease in pregnancy encountered. Okay, and the incidence of obstetric cholestasis is around 1 to 1.5% in Indian Asian population. We'll see some risk factors for this disease. So, risk factors include advanced maternal age, multiple gestation, chronic hepatitis C, then family history, or even past history. Okay, so if she already had a history of obstetric cholestasis, then the recurrence risk is around 60 to 70%. Clear? Now we'll see the etiology of obstetric cholestasis. So First factor is genetic factor. Okay. So, this is seen increasingly if there is a family history in first degree relatives. Okay. See, in these people, there is a mutation with a gene called as ABCB4 gene. Okay. So, there is mutation in this gene. It is basically encoding the phospholipid translocator. Okay. So, any problem with this gene, there is disturbance in bile secretion. Okay. So, this gene mutation can cause intrahepatic cholestasis in pregnancy. Okay. So, we will see the hormonal factors. See, this condition is high in women who are having increased levels of estrogen and progesterone. Okay. Suppose if they are prone to get this condition, if you see, normally itself the hormonal levels are going to increase during a third trimester. So, the peak levels of the hormones are seen in the third trimester. Hence, the presentation of this disease is mostly in the third trimester. Can you understand? Yes. And the second condition with the increased levels of estrogen and progesterone hormone is multiple pregnancy. Right? And the next condition is people who are taking oral contraceptive pills. Okay. So, that is why most of the times if you are planning delivery, okay. So, delivery is planned and when you are completing the delivery means this will terminate the disease progression also. Clear? Yes. Next is we will see some environmental factors. Some studies say levels of low selenium levels and low vitamin D levels can also cause cholestasis in pregnancy. Okay. So, we will see the clinical presentation. The single most important presenting feature of obstetric cholestasis is pruritus. Okay. If you take pruritus, this can be anywhere between mild to intolerable in grade of severity. Okay. Intolerable. Okay. And then it is mostly seen worsening at the night. Okay. And the pruritus can be generalized pruritus or sometimes this can be localized also. Okay. So, localized to palms or soles. Okay. And it is most commonly seen in, yes, second or third trimester. Okay. And if pruritus starts, then almost within a month. Okay. So, within a month, in some 10 to 15% cases, jaundice can set in. Okay. So, that is very important. Okay. And coming to the other findings include right upper quadrant pain, there can be nausea or poor appetite, sleep deprivation, there can be dark colored urine, pale stools, okay, and even sometimes steatorrhea is seen. Okay. Clear? Now, we will see the examination findings. On examination, if you do general examination first, you will be able to see secondary lesions like scratch marks. Okay. Number 1 is, you will be able to see secondary skin lesions like scratch marks or excoriations in pregnancy. Okay. And suppose there is, usually as I told you, there will be jaundice also, right? So there can be jaundice also, and previously I have told you, after the skin lesion started, that is after the itching starts in, the jaundice is going to appear within 1 month, that is 1 to 4 weeks, the jaundice is going to appear. Suppose there is jaundice without itching, means you have to think about other causes of jaundice also. Clear? Yes. We'll go for the lab diagnosis. Serum bile acids are elevated. Okay. Sometimes this can be the only abnormality, and it is the first abnormality to appear in a case of cholestasis. Clear? Okay. And there can be elevation in serum transferases or the ALP or even the total and direct bilirubin levels, but these are minimally elevated. Okay, or maybe absent also, but serum bile acid elevation is very important. Okay, and also there can be associated vitamin K deficiency, but PT, APTT and INR usually remains within normal range. Clear? Okay, but even before you are able to see these lab findings, remember pruritus is the first and important most symptom that occurs. Okay. If we see the pathology, there is cholestasis without inflammation. Okay. What is going to happen is bile is going to purge in hepatocytes and canaliculi. Clear? And if you check for any USG findings are not that specific. Okay. And if you ask me for the differential diagnosis of this condition, there are so many conditions, but it is pruritus gravitarum, that is very important because of the itching condition. But here the LFT remains normal. Clear? Okay. We will see the fetal effects of this disorder. So fetal effects, what is going to happen is the maternal bile acids that are getting accumulated are going to cross the placenta. Okay. So maternal bile acids cross the placenta. Okay. And it can get accumulate in the amniotic fluid or directly in the fetus itself. Clear? So what are the presentations you can have? There is increased risk of preterm labor. Okay. This preterm labor can happen sometimes spontaneously, but if the condition is so severe, there can be a chance of iatrogenic termination also. Okay. And there can be meconium stained liquor, since it is accumulating in the amniotic fluid. Then sometimes it can even result in IUD or stillbirth by fetal arrhythmia. Okay. And in some cases, if the baby is born normally, then the risk of neonatal respiratory distress syndrome is increased. Clear? Now we will see the treatment. For the mother, the drug of choice is ursodeoxycholic acid. Okay, so it is ursodeoxycholic acid. Okay, so if you see, this is a secondary bile acid. The dose can be anywhere between 300 milligrams BD or TID. Okay, and if you give this drug, the pruritus reduces in another 1 to 2 weeks. Okay, and the biochemical changes, the liver parameters decreases in another 3 to 4 weeks. Okay, so while you are giving this drug, you have to monitor for the bile acids every week. Okay, weekly once you have to monitor for the bile acids levels. So there are some points you have to remember if you are starting this ursodeoxycholic acid. Number 1, okay, don't increase the dose just to bring the lab values normal. Okay. Number 2, even if the lab values become normal with ursodeoxycholic acid, you are not going to change the plan of delivery. Okay, do not change the plan of delivery. And remember, empirical ursodeoxycholic acid is not recommended. Okay. Suppose if pruritus is not controlled with ursodeoxycholic acid, you can even try S-adenosylmethionine or rifampicin or cholestyramine. Okay. Suppose if this is not working, then you can try other drugs like S-adenosylmethionine, cholestyramine or rifampicin. Okay. And for pruritus, simple measures like local application of calamine can help. Clear? Right. Now we will see the fetal monitoring. During antenatal period, twice weekly at least, you have to offer them NST or biophysiological profile. Clear? And when to plan the delivery. See, delivery levels can be planned based on the bile acid levels. Okay. So, if the bile acid levels are less than 40 micromole per liter, then you can plan the delivery between 37 weeks to 38 plus 6 weeks. Okay. Suppose if the bile acid levels are between 40 to 90 micromoles per liter, then you can plan the delivery between 36 weeks to 37 weeks. And suppose if the bile acid levels are more than 100 micromole per liter, then you can plan it around 36 weeks also. Clear? Now remember these facts. Once labor begins, okay, once labor sets in, ursodeoxycholic acid is stopped. Clear? Now usually after delivery, pruritus will disappear. Okay? And also, don't forget to check her bile acid levels after delivery also. So, bile acid levels are checked after a week at least. Clear? And labor, mostly will try normal vaginal delivery, and for obstetric indications only will go for cesarean section. Okay? And then remember that breastfeeding is not contraindicated, and for contraception you are going to give non-hormonal contraceptives. Okay. So we'll discuss about acute fatty liver in pregnancy now. Okay. So acute fatty liver in pregnancy. See, this disease, one of the rarest disease, but it is one of the catastrophic disease also. Okay. Because it is going to affect both the mother and the fetus. and it can be potentially lethal for both. Okay, if the diagnosis is delayed. Okay, and if you take the incidence, it is around 1:7,000 to 1:20,000. Okay, and this also most commonly presents in the third trimester or early in the postpartum period. Okay, early postpartum period. Clear? Now, we will see the pathogenesis. See, pathogenesis can start either from the mother or the baby. Okay, so if you take the mother, there is a gene mutation in the gene G1528C. Okay, so this gene encodes for mitochondrial fatty acid oxidation. Okay, so if this gene is affected, then fatty acids are going to get accumulated. Okay, so fatty acids are accumulated in the liver. Okay, clear? Next is in the fetus. In the fetus, there is deficiency of 3 enzymes. Okay, there can be deficiency of 3 enzymes. Sorry, repeat. In the fetus, there can be deficiency of any of the 3 enzymes, namely long chain 3-hydroxyacyl coenzyme A. Okay, then medium chain 3-hydroxyacyl coenzyme A or CPT1. Okay, and CPT1, that is carnitine palmitoyltransferase 1. Okay, see, all these enzymes are responsible for oxidation of fatty acids in the fetus. Okay, suppose if this is not working, then what happens is there is retention of fatty acids in the fetus. Okay, so this is going to cross the placenta and it enters the maternal circulation and starts accumulating in the mother's liver. Clear? So, we will see the clinical features of this disease. So, clinical features include, I already told you, the gestational age of presentation is in the third trimester. So, it happens mostly after 30 weeks or near term or even in the early postpartum period. Now, the symptoms include gradual onset of nausea, anorexia and malaise. Okay, and the most important specific clinical feature you will see in this disorder is hypoglycemia. It is seen in 70% of the cases. Okay, so you will also be able to see hypoglycemia, and there can also be severe abdominal pain or vomiting. Okay, so this can be seen in 60% of the cases. Okay, and then after this, jaundice sets in within 1 to 2 weeks. Okay, and ascites can also occur and it can lead to hepatic encephalopathy also. Okay, and there is chance of renal impairment that can result in acute renal failure. Okay, which can present as sudden onset in BP, or there can be proteinuria. Okay, and there can be coagulation failure. Okay, DAC can also set in, and multi-organ damage and dysfunction can also occur. Clear? Yes. Now, the criteria that is used for diagnosis of acute fatty liver in pregnancy is known as Swansea criteria. Okay, just the name alone you know. Okay, and regarding differential diagnosis, the closest differential diagnosis for acute fatty liver in pregnancy is HELLP syndrome. Okay, but the differentiating features are in AFLP, you will be having features like hypoglycemia, and it can end up in renal failure. Okay, so these are the differentiating features. Okay, investigations. If you take the lab count, usually the platelet counts are more than 1 lakh. Okay, and the LDH levels are normal. Sometimes PT, APTT and TT can be increased. Okay, there is hypoglycemia as we have already seen, and the bilirubin levels can be elevated. Okay, and there is also increased serum creatinine levels. Okay, so bilirubin levels are elevated more than 5 mg per deciliter, and creatinine levels are elevated more than 1.7 mg per deciliter. Clear? And there can be neutrophilia and leukocytosis also. Clear? Yes. Next one is, we will see the pathology. Okay, so however, gold standard investigation is liver biopsy. Okay, gold standard investigation in this condition is liver biopsy. So, you will be able to see microvesicular fatty infiltration of the hepatocytes. Most prominent in the control zone with periportal sparing. Okay, and remember, there is little or no inflammation and there is no hepatocellular necrosis. Okay, so there is little or no inflammation and there is no hepatocellular necrosis. So, how we are going to manage this condition? Yes, again we are going to expedite the delivery. So, management, usually you have to expedite the delivery. That will improve the prognosis in both the mother and the fetus. Okay. Caesarean section as usual is indicated only for obstetric reasons. Okay. And for the infants, there are risks of fetal non-ketotic hypoglycemia, or there can be progressive neuromyopathy, and sometimes dilated cardiomyopathy can also be there. Clear? Yes. Now we will see viral hepatitis in pregnancy. We will see viral hepatitis in pregnancy. This is one of the most common cause of jaundice in pregnancy. Okay, suppose the deaths in jaundice in pregnancy are 10 to 20%, and among this, 90% of the deaths are due to viral hepatitis alone, and it is most commonly due to the viral hepatitis than chronic hepatitis. Okay, so understand the difference. And among this, remember one important fact that hepatitis B virus has the highest transmission to the fetus, and it is the most commonly seen hepatitis. Okay, seen hepatitis even in pregnancy. Okay, but hepatitis E virus, especially when it presents as an acute condition, there is a high mortality rate in pregnancy. Clear? Yes. Now, we will see hepatitis A. Okay. So, if you take hepatitis A, we will see the general features of this virus first. We know hepatitis A is a RNA enterovirus, right? And transmission of this virus is mostly by fecal-oral route. Okay, and also via the infected serum. And if you take the incubation period of this disease, incubation period is anywhere between 2 to 7 weeks, but most commonly we can take 4 weekly as an average. Okay, and the symptoms of the virus is shed in blood, saliva and urine also. Okay, so symptoms include weakness, fatigue, malaise, hepatitis infection, so definitely fever can be there. Okay, then usually it is a mild self-limiting illness. Okay, and chronic infection does not occur. There is also no carrier state. Okay, so if you take the lab diagnosis, the LFTs are elevated. There is elevated levels of AST and ALT, and also if you check the serum for antibodies, you can have anti-HAV IgM if there is a recent infection in the past 4 to 6 months, or there can be anti-HAV IgG if the infection has been present for years. Clear? Yes. And next one, we will see the importance of this infection in pregnancy. Okay. So, in pregnancy, if you ask, the incidence is around 1:1000. Okay, and this is not transmitted to the fetus in utero. Okay, to the fetus in utero. If the mother is infected in the 3rd trimester, okay, if the mother is infected in the 3rd trimester, then post-exposure prophylaxis is needed. Okay, with immunoglobulin to the infant. Clear? Yes. Next is, so how you can prevent the spread of this disease? First, improve the sanitation. There should be strict personal hygiene. Including hand washing. Then avoid exposure to infected individuals. Okay, and if exposed, post-exposure prophylaxis with immunoglobulin at a dose of 0.02 ml per kilogram can be given. within 48 hours. Okay, and for antenatal care, there is nothing specific. You can give a routine antenatal care. If required, hospitalize the patient and check on her fluid and electrolyte balance also. Clear? Yes. Next is hepatitis B infection. This is a DNA virus. Okay, so this is a DNA virus. Transmission occurs through the body fluids. It can occur via the blood, vaginal secretions, semen, saliva and breast milk. Okay, and there can also be transmission by contact with broken mucosa or skin, and if it is a chronic HPV infection, the infection is going to spread to 70 to 90% cases to the fetus. Clear? And then percutaneous transmission also seen. Okay, so percutaneous transmission also seen. Okay, now if we take the presentation, see, most of them are asymptomatic. Okay, so that is around 70% of them are asymptomatic, and they can present as acute or chronic infection. Okay, so if you take incubation period, it is around 30 to 180 days, and average you can keep around 90 days. Okay, so what is going to happen is, if there is chronic hepatitis, it is going to form cirrhosis and it can form hepatocellular carcinoma also. Clear? Right. Now, what is the importance in pregnancy? Okay. In pregnancy, if it is an acute infection, this can be managed as a benign condition. Okay, there is no increased risk of teratogenicity or death. Clear? But for the fetus, there is a increased risk of low birth weight and prematurity. Clear? So, what are the symptoms that the mother can present with? Symptoms basically can be classified into symptoms occurring in preeclamptic phase and icteric phase. Okay. If you take in the preeclamptic phase, most of the time she present with anorexia, malaise. Okay. Then there can be fatigue or fever or right upper quadrant pain. Clear? And in the icteric phase, she can present with nausea, vomiting, or icteric means jaundice. So, definitely jaundice. Then there can be pruritus, there can be hepatomegaly, that is enlarged and tender liver also there. Okay. So, if you take, if all these symptoms are presenting also, 90% of them can improve. Okay. And 10% of them will progress to chronic hepatitis condition. Clear? Now, how we'll do screening and diagnosis in pregnancy? So, screening and diagnosis in pregnancy. This infection is to be screened routinely for all antenatal women. Okay, so you should offer a routine screening. If they fall at a high risk group, again screening at 28 weeks is done. Okay, then you have to detect the HPV serum marker while screening. Okay, and suppose if she is in the window period and if you are doubtful, you can screen for HPC antibody. Clear? And chronic carrier state means they will be carrying HPS antigen for more than or equal to 20 weeks. Clear? Okay. And next one is, remember, transmission to the fetus can occur in all the states. Okay, it can occur in the antepartum period or intrapartum period or even in the postpartum period, but it is more during the intrapartum period. Okay, and without immunoprophylaxis, the risk of mother to child transmission can be as high as 90%. Clear? If there is HPE antigen positivity in the mother, okay, and there is a high viral load, this transmission risk is more. Okay, and hence we advise antiviral therapy for women, which is the preferred drug for hepatitis means it is tenofovir. Okay, and this can be ideally started around 28 to 30 weeks. Okay, so why we are preferring this time period means by this time, number one, organogenesis is complete. Okay, there is enough time for the HPV DNA levels to decline also. Clear? Yes. And for the infants, you have to give their first dose of HPV vaccine, preferably within 24 hours of birth. Okay. Suppose if the infant was born to a HPS AG antigen positive mother, then they should additionally receive hepatitis B immunoglobulin also. Okay. If you are combining both these things, if the mother had a high levels of HPV antigen positivity or HPV DNA levels, then the efficacy of the drug improves up to 90 to 95%. Clear? HPV immunoglobulin doses 0.5 ml intramuscularly and hepatitis B vaccine doses the same 0.5 ml IM, but you should give it a different size if you are administering both immunoglobulin and vaccine. And remember, you have to repeat the dose at 1 and 6 months again. Clear? Right. We'll see hepatitis C now. So, hepatitis C, this is one of the most common cause of non-A and non-B hepatitis. Okay. So, most common cause of non-A and non-B hepatitis. Okay. And if you take this as a single stranded RNA virus, and this is transmitted parenterally, perinatally, sexually, and also in healthcare settings. Okay. If you take the incubation period, it is around 30 to 60 days. And the incidence in pregnancy is between 1 to 2.4%, and among them 3 to 5% of the infected mothers transmit the disease to their infant or fetus. Clear? Okay. Now, what are the clinical features in this disease? So, clinical features, they can be asymptomatic mostly in 70 to 80% of the cases. Then in 25% there can be symptoms like abdominal pain, jaundice or fatigue. Clear? And suppose if they are presenting with acute infection, they can even result in hepatic failure, and suppose if they are presenting with chronic infection, there can be chances of hepatocellular carcinoma. Clear? Right. We'll see the lab diagnosis. In acute HCV infection, the lab parameters, that is the transaminases, raise up to even 7 folds. Okay, and you can do qualitative PCR assays for viral particle detection. And to guide gene therapy, and viral genotyping can also be done to guide therapy. Clear? Yes. Now, we'll see the importance in pregnancy. So, in pregnancy, there is a need of screening, especially in high risk cases. Usually, vertical transmission in hepatitis C doesn't occur. So, vertical transmission not seen, and highest risk of vertical transmission can be there, okay, when it is co-infected with HIV. Okay. So, if you take isolated HCV mother to child transmission rate, it is only 5%. Okay. Suppose HCV is co-infected with HIV, means the transmission rate increases up to 15%. Clear? And in this case, remember, for delivery, cesarean section is not recommended. Okay, and as usual, breastfeeding is not contraindicated. Clear? Yes. Next, we will see hepatitis D. Okay, so hepatitis D is an incomplete virus. Okay, and we all know it requires, yes, hepatitis B for replication. And remember, perinatal transmission of this virus is rare. Okay, and more rapid prognosis to cirrhosis or portal hypertension or even hepatic failure is seen if co-infection is present. Okay, and the management of this condition is same as hepatitis B. Clear? So, we will see hepatitis C. See, this condition is endemic in India. Okay. So, remember, this causes the highest maternal mortality. Okay. So, if hepatitis E infection is occurring, it is going to cause the highest maternal mortality. But which is the most common cause of mortality due to hepatitis? It is hepatitis B. Okay. So, when they give the common cause of mortality due to hepatitis, you have to choose hepatitis B. And the highest mortality rate is seen with hepatitis E. Clear? Yes. And transmission of this virus occurs via the contaminated food and water. So, there is fecal-oral transmission and vertical transmission is also seen. Okay. So, the incubation period of this virus is around 2 to 9 weeks, average around 45 days. Okay, clear? And then what are the clinical features? Clinical features are similar to HIV. Okay, so they are similar to HIV and it is a fulminant disease in 10% of the cases, and remember there is no carrier state for this disease also. Clear? Yes. So, how will be doing lab diagnosis? We do HEV RNA. Okay, and we can even check for the virus specific antibody. Clear? And then during pregnancy, there is a most severe disease course, okay, among all the hepatitis. And as I have already told you, there is high mortality rate also, that is around 10 to 18%. So, need of hospitalization can be there, and the drugs like ribavirin or pegylated interferon alpha, okay, are contraindicated in pregnancy, okay, because these are associated with the risk of teratogenicity. Okay, so there is a risk of teratogenicity. Okay, and for the mother, there is a risk of postpartum hemorrhage, or even there can be chances of preterm birth. Clear? And fetus risk includes prematurity or low birth weight. Okay, and there is increased risk of perinatal mortality and morbidity also. Clear? So, with this we are finishing the discussion on jaundice in pregnancy. We have done with the two important disorders specific to pregnancy and also about all the hepatitis disorders. Hope this would have helped you. Until we meet in the next video, take care, happy learning, and bye-bye.